Hi, everybody, and welcome to the fifth COVID Community Town Hall sponsored by the Stanford Cancer Institute Community Outreach and Engagement Program, the Stanford School of Medicine, Office of Community Engagement, and also our Department of Epidemiology and Population Health. My name is Lisa Goldman Rosas. I'm an assistant professor in our Department of Epidemiology and Population Health, and I direct our Office of Community Engagement, and I get to be your moderator today. So next slide, please. So the goal of our town halls has been to give you up-to-date information and provide you an opportunity to ask our experts all your burning questions about COVID. Today, we have a special opportunity to focus on cancer and how the pandemic has affected cancer screening, cancer prevention, treatment, and survivorship. So the way it's going to work is we will have brief presentations from four wonderful panelists who I will introduce to you in just a minute. And then we'll provide the majority of the time to ask your questions. So with that in mind, I want to go to a few housekeeping items to help this run smoothly. So first, if you would like interpretation in Espanol, you can find this little world button at the bottom of your screen. And when you press that, you will get to hear simultaneous translation from two live interpreters, Claudia and Esperanza, who are on the line, waiting and willing to translate everything we are saying. So second, many of you submitted questions when you registered, which is wonderful. Thank you so much for that. And we will get to as many of those questions as possible. You can also submit questions live, and we hope you do. Please use the question and answer button at the bottom of your Zoom screen to submit your questions. Sometimes we might not answer your exact question, but we'll try to cover the topic that your question addresses. And today, we also have an additional opportunity for getting your questions answered. We have a physician who will be monitoring the Q&A with us and will attempt to get to some of those questions that we can't get to live. Okay, oh, and you can also, se pueden poner sus preguntas en español si quieren. We have a bilingual team, so we will answer them in English and Spanish as we're able. Okay, with that out of the way, we're going to go ahead and get started. I am so pleased to introduce our panelists. So next slide, wonderful. We have assembled a really stellar set of presenters today, and I'm going to briefly introduce them, and then they will get an opportunity to tell you a little bit more about their work. So first, we're going to hear from Dr. Melissa Bondi. She is professor and chair of the Department of Epidemiology and Population Health. She is an epidemiologist. Next, we will hear from Dr. Elwin Kabibi. He is a medical oncologist in our Stanford Cancer Center South Bay. Then we'll hear from Dr. Lidia Schapira. She is also a medical oncologist, and she directs our Stanford Cancer Institute Survivorship Program. And then Dr. Steve O'Brien is the Chief Medical Officer at Alameda Alliance for Health, one of our key partners. Okay. And if you've seen one of our town halls before, you know we always do a little icebreaker with each of our panelists so that you get to know them a little better. So because it's Halloween on Saturday, I thought I'd ask each of our panelists to share their favorite Halloween costume before they present. So be thinking about your favorite Halloween costume. So I'll go first. Let's see, my favorite Halloween costume, I think recently was I dressed up as Frida Kahlo because when I lived for some time in Mexico, I lived in the neighborhood where she lived, and it really reminded me of that. Okay, so Dr. Bondi, you get to go first. I see your slides are up and ready, but before you go, we're gonna make you share or ask you to share your favorite Halloween costume.
Lisa, you make this really difficult. I'm thinking back because I don't always celebrate Halloween as my kids are older, so I'm not a big Halloween fanatic, but you know, when I was a kid, I always liked, of course, as most girls did at the time, like to be a princess. And so I would usually dress up in kind of little princess outfit and would go trick-or-treating. And I loved to trick-or-treat as a kid and always had favorite places to go. And one of my good friends would have, father owned a bakery, and they would always have hot chocolate and donuts. And I always thought that was like really great. So that's one of my Halloween stories. But anyhow, I'm also the Associate Director for Population Sciences in the Cancer Center. And so this is a great opportunity for us to reach out to the community, talk about cancer, and also cancer screening. And that's what I'm going to talk about today. Next slide, please. So here's just a short overview of the impact of COVID-19 pandemic on cancer diagnosis. And we know that there's been delays in screening. I have to admit, I've also had a delay in my mammograms and my screening. And part of it is just getting to the clinics and having this done, making appointments and things like that. I'm going to talk a little bit too about possible effects on the long-term outcomes of cancer and show you some information that's been in the minds of the people at the National Cancer Institute who have been looking at some of these delays. And then I'll just discuss a little bit also about screening guidelines and what's recommended by the National Cancer Institute and the American Cancer Society. Next slide, please. So these are some of the potential impacts of COVID-19 on long-term trends in cancer statistics. So of course, I just mentioned about delayed diagnosis. And from the delay of the diagnosis, people would reduce their screening practices, possibly reduce follow-up on suspicious findings of their screening because they may not be able to get into the clinics on time, and also reduce visits to address some of the symptoms that if somebody has a symptom, they may just put it off and not seek screening or even care from their physician. And because of these delayed diagnoses, there could be treatment delay and potentially in the future increased mortality. And I'll show you a little bit of information about that. Also deferred care, and I think we'll be talking about that in a little bit. We know that when COVID started, a lot of the clinics weren't open and seeing patients as quickly as maybe people needed to be seen. There was postponing of surgery. Some surgery practices were seeing patients at a reduced rate because of worry about COVID and people coming into the clinics and the hospitals because they were worried they might be infected with COVID. Postponing of treatment and radiation treatment. And because of some of these deferred care, there was a treatment delay and potentially it could lead to increased mortality. Also, we're concerned about reduced or non-standard care, and I think these will be talked about as the other speakers talking about what the effects would be from not having their treatment as maybe directed because the clinics might have had reduced hours or people being able to get into the clinics. So because of that, they may have been less intense chemotherapy, neoadjuvant chemo instead of immediate surgery, which could have an impact on their long-term outcomes. So reduced response also could increase mortality. So this could go in different directions with the way showing these arrows with reduced access to care, and this could affect mostly uninsured, underinsured, or underserved populations. And so we were concerned of what this effect could have on the population. Next slide. So this was some calculations of excess death that could occur, and this was produced by the National Cancer Institute, and this was an article that just was recently published in the journal Science by Dr. Ned Sharpless, who is the director of the National Cancer Institute. So this is if we look at both delays, as I just mentioned, and how they were looking and modeling the cumulative excess of deaths because there could be a delay in treatment, a delay in diagnosis, and maybe some other modifications that could have occurred in their treatment, as I just mentioned. So what they're looking at here in terms of the number of excess deaths, that if women could have had a diagnosis of breast cancer and was not seen, and we all know that it's important to we would want to achieve early diagnosis because that would really impact the the survival benefits. So you can see here that the numbers over time through 2030 that we could be seeing definitely, if this is the case, an increase in mortality later on if there is this type of delayed diagnosis and people not being able to get the proper treatment at the time they need to have it. Next slide. So what about screening? And just so we keep in mind what the screening guidelines are, and for regular screening, and this was published on the American Cancer Society's website, and this is some just so people have in mind that for breast cancer age 55 plus, that women should screen every 2 years if the mammogram was normal. Otherwise, they recommend annual mammograms between 50 plus. For colorectal screening, some of these types of screening could be done at home safely. And if there is a positive result from these types of in-home tests, like the FIT test or Cologuard, then it's really important for the individual to schedule an appointment with their healthcare provider for a colonoscopy or for follow-up from their healthcare provider. Cervical cancer's a little bit different. They recommend PAP tests every 3 years, and they recommend a PAP with HPV if that's normal every 5 years. But again, if there's any problems or if somebody's having a concern, they really need to consult with their healthcare providers. And what's also important, and this was a question that came up before before we started the program today, that some people were concerned about getting access to their physicians and scheduling their appointments because of the difficulty of getting appointments. And so it's really important to schedule, even if you need to schedule a few months ahead, but just to get on the schedule to be able to go in and have your screening exams done. Next slide. So I want to thank the participants, and we're really happy that you joined us today. And remember, please follow screening guidelines, make your appointments, and we do know, and you can remember from the slide that I showed, that if there is a delay, there could be really strong issues later with a increase in mortality if you don't plan ahead and follow screening guidelines. So thank you, and happy to answer any questions.
Wonderful. Thank you, Princess Melissa. That was wonderful. I did see Dominique had a question on the chat asking if the data you showed for excess deaths were from the United States only, or was that international?
They were from the United States, but I would assume any delays around the world could also have the same situation with increase in excess mortality.
Great.
And that's what we want to avoid. We want to go back to the 2020 numbers where we were able to keep things under control with treatment on schedule.
Wonderful. So thanks, Dominique, for putting that first question in there. That's great. We are going to move to the next speaker. I also see a question from Daniel reminding us that we also need to think about vaccinations as a cancer prevention and not to delay those. So thanks, Daniel. My son got his HPV vaccination yesterday, so that is a very good reminder for everyone. All right, and for the speakers, I want to remind you we have someone translating for you. So when you pause, it will help us catch up so that those who are listening in Spanish get all the information that we get in English. Okay, so Dr. Kabibi, you're next. And if you could share your favorite Halloween costume, we would love that.
Hi, everybody. Yeah, Lisa, you caught me off guard there. I have to tell you, long before there were cell phones and where you could take video on phones, there was something called a VHS. And I know my cousins that are probably on the line are gonna totally laugh at this, but there's a VHS recording of me, I guess maybe in 7th or 8th grade, as a jail person, all in like jail gear and the black and white, etc. And all of my younger cousins making fun of me and making fun of myself. So those were fun times, carefree times that I can think of. So I really wanted to extend a very warm welcome to everyone during this challenging time. I really appreciate being a part of this town hall. and appreciate everyone that's put this together. I've been asked to share my experience in treating cancer patients during this time of COVID, and also highlighting how we are refocusing and adapting to meet that challenge. Next slide. So these are some talking points that I was asked to touch upon. Why cancer patients who have compromised immune systems may be more vulnerable to COVID-19, the concerns of current cancer patients in active treatment, how medical oncologists are addressing these concerns. And I first want to start off by saying that cancer diagnosis in and of itself is a very isolating disease. And when you add the clouds of COVID-19 on top of it, it becomes very, very dim. And cancer patients are really the poster child for those who are immunocompromised, which by definition means that their immune system is much more fragile than that of a healthy adult. Cancer patients also tend to be older. They also are on treatments that could significantly decrease their immunity just by the way the treatments work. And so it is very challenging. And I think to highlight some of these concepts that we are to talk upon, I'd like to maybe share a few stories of my personal experience taking care of patients. I remember in the March at the beginning of the epidemic, I admitted a 40-year-old male young father who had acute leukemia and was isolated for 7 days waiting for a COVID test. And this was before we were able to ramp up testing. And I remember hand-holding him throughout his hospital stay, not able to see any family member, being given a really significant diagnosis, a life-threatening cancer diagnosis, and potentially a life-threatening infection as well. Fortunately, he was COVID negative and is continuing on with treatment. In the clinic, for myself, I've had to make a lot of adjustments in taking care of cancer patients. I've had to delay potentially curable surgeries for patients. I've had to switch treatments from intravenous infusions to oral infusions, oral therapies in order to allow them to not be at risk for coming into the center. I've had to have telephone talk about prognosis over the telephone through telemedicine, which they never taught you that in medical school. And certainly is very disheartening for me to not to be able to connect with patients with that information of their cancer and what that means. Seeing new patients with masks. I've always joked that even though I met them, I'm not ever going to really recognize them outside of them wearing their mask, and not understanding the social cues and really connecting with patients and how they're dealing with the information that we're talking about. And the final story I would like to share is I had a metastatic breast cancer patient who was going through treatment and diagnosed during this pandemic and developed a significant amount of depression during this time. He came to me and said, Dr. Kibibi, you know, I only have so much time to live, and I'm going through these chemotherapy treatments, but I'm not able to hug my grandchildren. I'm not able to spend time with my family. I'm not able to travel. Why is it really worth it for all the efforts of going through this treatment when I can't achieve the quality of life that I'm trying to earn? So those are just some examples of really the difficulties that it has been in terms of managing patients. Next slide. I think what I'd like to highlight is a couple of research initiatives that Stanford is a part of, and I'm personally a part of, that help to explain how we're trying to evaluate risks for COVID infections and patients with cancer that develop COVID, as well as how it's transforming our delivery of cancer care to these patients. Next slide. The first consortium that Stanford is a part of is the CCC-19 COVID-19 and Cancer Consortium. This is a consortium of 120 institutions across the United States, 5 of which are in Canada, and many of these are National Cancer Institute comprehensive cancer centers. And the goal of this consortium is to collect data on cancer patients who develop COVID through this program called REDCap, and then inputting all the patient demographics into this data tool, and then analyzing the data to look for trends. At Stanford, Dr. Sumit Shah is our principal investigator. I am a co-investigator, And Dr. Lidia Schapira, who you will listen to shortly, is also a co-investigator. Next slide. One study that CCC19 has shown was that there are selected risk factors associated with death from COVID for patients who have cancer. And those characteristics include older age, lower performance status, meaning how functional they are, if they're very low function, male sex, if they have progressive cancer, smoking, hematologic, or if you have more than one cancer, if you have more than 2 comorbidities or other medical problems, and if you developed a severe baseline COVID-19 at presentation. With regards to the cancer patients that are undergoing treatment, patients who are treated within 1 to 3 months from their COVID-19 diagnosis, and those treated with chemoimmunotherapy have shown to have the higher risk of death from COVID. Next slide. So the registry is now at nearly 5,000 patients. There are multiple sub-projects underway, including cancer patients with different complications, patients on immunotherapy. We're looking at racial and ethnic disparities as well as regional disparities. And in addition, the registry is expanding to Latin America, to other countries. And so we should see more data coming forward. Next slide. The American Society of Clinical Oncology, or ASCO, also has a survey on COVID-19, and they also have a registry. They utilize a platform called CancerLink, which basically is a large database looking at collecting electronic health record information from participating institutions, and again, creating a registry looking at patients who are cancer patients that develop COVID-19. Next slide. The ASCO registry for COVID-19 was launched in April 2020, and as of last week, there were 57 practices practicing across the United States, and more are joining weekly. Next slide. When we presented our data in July, we looked at changes to cancer care delivery during COVID-19. And what we found was of the participating practices, all practices were still accepting new cancer patients. And actually 70% of the practices were scheduling appointments without delay. Interestingly, every practice was using telemedicine for patients in terms of routine follow-up. And about a third of practices were actually doing both follow-ups and new patient visits all through telemedicine. Half of the practices were adjusting their treatments to reduce either the need for the patients to come into the clinic or their time into clinic. And that included switching from intravenous therapies to oral therapies, or even shortening the time of their infusions. About 80% of the practices had reported some shortages in personal protective equipment. Fortunately, none of the practices reported any shortages in anti-cancer drugs. Next slide. I really want to highlight a study that CancerLink and ASCO has presented, and basically it was looking at Black and Hispanic cancer patients. And what they looked at in the CancerLink database was that Hispanic cancer patients, as well as Hispanic cancer patients had a 5 times, and Black cancer patients had a 1.7 times higher likelihood to develop COVID compared to those of their white counterparts. And I think that's really unmasking the social inequities and health disparities that we are struggling with in this country today. The Stanford Cancer Institute and the Community Advisory Board, which I'm a part of, and Whitney Green is leading, is looking at innovative ways to really address the needs of these marginalized communities and groups. Next slide. CancerLink also noted that patients with hematological or blood cancers also had a higher risk to contract COVID-19 compared to those patients who were dealing with more solid tumors. Next slide. So what I would like to do is empower both the cancer patients and their caregivers that are at this meeting to look at some questions that you should consider. I think if you're going through treatment, you should ask, what are the clinic and hospital screening policies for both the employees and patients coming in? What are you doing to ensure my safety? And here at Stanford Hospital, as well as our associated community clinics, we've been very diligent about really protecting our patients and our employees and really aggressively screening. Other questions you should consider: what can I do to protect myself and my family during COVID? Is there anything more I should do based on my daily circumstances? Can I undergo an immunosuppressive treatment for my cancer during COVID? And what are the pros and cons of beginning or delaying during this time? Should I be COVID tested prior to beginning treatment? How often should I be tested? And should I schedule my routine screening or surveillance, or should it be delayed? I thank you again for your time, and I'll pass it on back over to Lisa.
Thank you so much, Dr. Kabibi. You really gave us insight into what it's like day to day, and it's great to hear the research that you're doing. So I see you've got a few questions. Nell asked a question, and I see Dr. Wu has already answered it for us, so that's wonderful. Thank you. I think we'll keep getting your questions in, and we'll hold them off until the last panelist goes. So you're off the hook for now, Dr. Kabibi.
All right, I'm ready.
Thank you so much. Okay, our next panelist is Dr. Lidia Schapira. And Dr. Schapira is bilingual. So if you have any questions for her in Spanish, please go ahead and submit those. And I know she will be excited to answer them. And Dr. Schapira, you also get to share with us your favorite Halloween costume before you get started.
Well, that's a little complicated. I grew up in Argentina where we did not celebrate Halloween, so I have no childhood memories of being a princess or a witch. And so I've learned about Halloween as a mother. And because I am not very good at putting costumes together, I must say I always panicked a little bit at Halloween. And the only thing I've ever done is sort of wear a witch hat. So that's about as far as I go, and smile when kids come and ask for candy.
Very good. Thank you.
All right. Well, it's a pleasure to be part of this program today. And thank you very much for giving me the honor to be part of this panel. I would like to continue to address the themes that my colleagues, Dr. Bondi and Dr. Kabibi, started with, focusing really on cancer survivors. Next slide, please. So who is a cancer survivor? Let's start right there. The definitions that we have from the National Coalition of Cancer Survivors, the National Cancer Institute, is that anybody who's been diagnosed with cancer is a survivor from the moment that they hear they have cancer. That's not usually how we think of the population of survivors. We think of survivors as those who've finished their treatment and where the treatment was given with a curative intent. But these days we're quite generous in applying the term survivor to anybody who's living with cancer, anybody who's been diagnosed with cancer, and even we can extend that definition to those who give care and love somebody with cancer, because they too have had their lives disrupted and affected by cancer. So cancer survivors often say they feel lost in transition after they finish their active treatment, and they often feel that they don't know who to call when there's a problem. They often say that they feel bounced between doctors. They have a problem and they'll call their primary care or their oncologist only to be referred to the other. So we're very protective, those of us who really care about this population. And as you'll see in my comments, I'm constantly thinking about how we can make this better through better communication, through streamlining care, and to help patients and survivors and caregivers to feel that there's more integration in a system that may feel to them as being very fragmented. Some people don't like the word survivor. Some people tell me they're thrivers. Some feel that they haven't earned the right to call themselves survivors, and others just love it and wear it as a badge of honor. So I'm talking to all of you who have had cancer or been touched by cancer in a loved one. The medical community has responded to this recognition that there are now almost 17 million cancer survivors in the US, by recognizing that survivorship is a distinct phase of the cancer journey or the cancer care continuum. So we think of it more as what happens for patients who are living past their diagnosis or with cancer as a chronic condition. Next slide, please. So what does cancer care look like in the pandemic? Well, you've heard from my colleagues, Dr. Bondi and Kabibi, that decisions were made at the early phase of treatment without sufficient information. And as we're learning more about this, we're learning that in the first few months, decisions were made without any evidence at all, without any idea of how the virus affected patients with cancer. Now we have a little bit more data. And one of the concepts I'd like to get across to all of you is that perhaps the experience of being cared for or being diagnosed with cancer depends also a lot on when in the course of the pandemic you were diagnosed and where you lived. Your zip code matters because there were areas of the country where the surge in COVID cases basically forced a total interruption of cancer services, whereas other areas, including the Bay Area, we've been more fortunate in that after the initial panic, we were able to go back to something that felt a bit more normal within a reasonable amount of time. We've looked at, and Dr. Wu, who's one of the physicians who's helping us with the questions here, led a study even looking at Stanford and at our sister institution, UCSF, how we all responded to it. And what we learned is that we did our best with the information that we had. Fortunately, now we can still we can rely on our colleagues being able to handle elective procedures, and we are able to do screening procedures. But for those who were diagnosed early on, that really posed an enormous problem. So as you heard, the patients who were hospitalized and who were sick did not have the privilege of having a loved one with them. The doctors tried their best and the nurses tried their best, but they wore masks, they wore PPE. Our ways of relating to each other changed. Even now, people are not allowed to come into treatment areas, often with family, which we were all used to. We had gotten very good at encouraging patients to bring a caregiver, and then we immediately switched. Routine visits are not conducted in person anymore, and all of this may add to the burden of anxiety and worry for the patients, but also for family caregivers. So the fear of catching COVID or the fear of having vulnerable patients catch COVID drove decisions to change or delay treatment. And also those who had a new symptom wanted to stay away. There are many stories, especially from areas in the Northeast and the very early areas of the pandemic, of people just too afraid to go to an emergency room or an urgent care center when they had a complication of cancer therapy or a new symptom, just because of the fear of contagion. Next slide, please. So what happened to cancer research during the pandemic? Well, as you heard, the cancer community rallied to form large groups to accelerate progress in our understanding of how COVID affected people living with cancer. And that led to the formation of the Cancer Consortium, the CCC19 Consortium, and the ASCO and NCI initiatives that Dr. Khabibi described, and we are very proud to be part of as well. So what happened is that most of the cancer research community basically stopped what they were doing and tried to think about how we could come together to understand and help make these decisions through modeling of what would happen with delay of treatment, through changes in the guidelines that are driven by evidence and expert opinion, and collecting all of the cases so we could actually find out what happened to patients who were undergoing treatment or in survivorship and got COVID. But what happened to cancer research, on the other hand, is that it stopped. And that has led to some distress in our community and for our patients who were ready to enroll in a clinical trial because they hoped to get a certain treatment or participate in research, often found that they were not able to do so. So I think when we think about research during the pandemic, there are interesting and important lessons to learn about how the cancer community can come together, and also teaches us that during a time of crisis, the cancer research may actually be slowed down, and that may delay progress in terms of finding better treatments for cancer. Next slide, please. So Living with cancer and COVID poses extraordinary challenges with patients who have had to make decisions about their cancer treatment in order to protect their immune system. Patients who were unlucky enough to get cancer and COVID fought some hard battles to get better. And now we're learning also that COVID, just like cancer treatment, leads to some long-term problems. Those of us who look after cancer survivors have long understood that some of the exposures to cancer treatments then may lead to some adverse effects like neuropathy, to give you an example, that persist even after the cancer treatment is complete. And now patients who have had COVID find that some of the symptoms they have are also there for the long haul. So there's now active rehabilitation for those who have had COVID. And some patients with cancer lived in areas where the resources, unfortunately, or perhaps appropriately, were diverted to treat active COVID. So some of the patients with cancer feared that they would not receive proper care. Or if a patient who was a cancer survivor also had COVID, they feared they may not have access to intensive care because they also had the label of cancer as a pre-existing condition. And that's something that perhaps some of you will also have questions about and we can discuss later. Next slide, please. So cancer survivors tell us that they live with uncertainty, and the response of many cancer survivors has been, now everybody understands what it's like, because everybody is living with this uncertainty about COVID. How bad could it be? How can I stay safe? How long will it last? Will I be in line to get a vaccine when one becomes available? And also COVID, we have to face it, has led to economic hardship with job losses and often insecurity about how to pay for medical treatment or even food insecurity. So all of these things, I think, have intensified the anxiety and suffering of cancer survivors. And there will be mental health consequences. We're just beginning to tackle these due to more stress, more anxiety, lack of social contact, and even loneliness. Community support is so important. So it'll be interesting to reflect on how communities have come together to support people living with cancer, cancer survivors, and those with cancer and COVID. Next slide, please. So cancer survivors faced many challenges during the pandemic. There was disruption in the standard practices for follow-up, the contact with the health clinicians, and the delays in screening. Dr. Bondi said her own screening mammogram was postponed, so was mine. And so even those who don't have cancer worried more because everything that we had used to was interrupted. Now you can only imagine how much more intense this is for cancer survivors who were used to having an exam perhaps every 4 to 6 months, and all of a sudden that was converted to telehealth. So we don't yet know what the exact consequences will be from an evidence point of view, but we do know that there is more worry, and now we're trying to go back to practices that are more normal. So in the initial phase of the pandemic, we basically were very scared basically of having people come in. I think now we're much more comfortable knowing that we can do screening with minimal risks. We know for a fact that we have not exposed patients to the virus for coming to their outpatient visits and screening. So things may be normalizing a bit, but still the majority of routine visits will be conducted through telehealth, and that means fewer physical exams, fewer opportunities to really connect with a clinician. And even when you do, the encounters are going to be briefer and people are going to be masked, and there's not going to be the opportunity of having somebody else in the room. So the cancer community is trying to keep as many people as safe as possible, but certainly this is not going back to normal for a little while longer. Next slide, please. So finally, I'd like to end with some some good practical tips and a hopeful message. My feeling is that what I hear from cancer survivors, cancer patients, and from what I understand from all the research we've done into all the ways that we can support people living with cancer and their families over the years, is that good communication matters. And communication is really very active. It's not just what one part does or says. A patient of mine whom I love dearly compared it to a game of catch. And she said, you have to look and see where you're going to throw. The other person has to be ready to receive, and then they have to look, aim, and send it right back to you. So when we think about communication, it's important to think about how we can train cancer teams and primary care physicians to communicate with patients, but it's also important to empower survivors and patients and caregivers to ask their questions and know who to ask them to, and know how to get heard and hopefully get a good response back soon. People also need access to high quality information. And in this era, we worry so much about misinformation that I think it's important to think about good, reliable medical news and not fake news. So I'm going to give you one example of where you can get good quality information. And the other is that supportive services provided by cancer practices, treatment centers, large medical centers, and community organizations are really, really important in providing that peer-to-peer buddy experience, and also providing good supportive services for families, for kids, and for elders. Next slide, please. So one example of a site that I want to make sure you all know about is cancer.net. Cancer.net has information that is vetted by experts. These are the people that your cancer clinicians call for when they have a tough case, or often involve experts from many centers such as ours here. We have, I'm very involved with this. I'm the editor-in-chief of this site. It's put forward by a professional society of clinical oncologists. There's not a single advertisement on the site. We have 5 million people coming to the site every month from all over the world. And I'm so proud to tell you that there's content in Espanol and in other languages as well. We have a specific section that we started on cancer and COVID. The moment the pandemic broke out, we updated daily. We have experts, we answer questions. So this is one site that you can go to reliably and get good quality information. Last slide, please. So I want to end just by giving you some positive thoughts. One is that the pandemic led to us really have to think hard about how we can support people living with cancer in different ways without having to do that in person. It really showed us that cancer researchers and clinicians can come together at an incredible speed and that they can collaborate. It's accelerated the mechanisms for sharing data between institutions. Just think about it. We have 5,000 cases of patients with cancer and COVID that we've collected and analyzed. Just think about what we could do if we could come together just as quickly, for instance, to understand how to treat a rare cancer, where it's very difficult to have enough experience because there are just few cases around the country and around the world. It's forced us to grapple with important issues that have been staring at us for a very long time, but all of a sudden have really come front and center. And that is the important issue of health disparities and inequities. And now we cannot go back. We have to do something about it during and post-pandemic. And finally, as a lovely patient said to me this morning in clinic, you know, having cancer has helped me see things in a different way. The colors are brighter, and there's always something that I'm grateful for every day when I wake up. And so I think that as a cancer community, patients, researchers, and clinicians, it's also taught us the importance of social solidarity, because what happens, we all need to think constantly about what's good for all of us as a community, and not just what's good for us as individuals. And that, I think, is really an important lesson and something that we can all take with us forever. Thank you so much.
Wow, Lidia, thank you so much for ending on that positive note. I think there's nothing like a pandemic to teach us about solidarity and that we're all in this together, right? So thanks for that message. I see more of you are submitting questions and we're going to get to those. Please continue to submit those questions. Someone asked if their question was silly, and of course not. None of the questions are silly, and we're excited to get to all of them. So last but most definitely not least, Dr. Steve O'Brien, and he is the Chief Medical Officer for Alameda Alliance. And I realized when I said that in the beginning, Dr. O'Brien, we didn't even say what Alameda Alliance is, and maybe all of our attendees don't know. So after you talk about your favorite Halloween costume, maybe you can just give us a brief explanation for our attendees who aren't aware. Take it away.
Well, thank you for having me, and I'm very glad to be here. I am a fan of Halloween and certainly was as a child, both for the costumes and the candy. But I remember a particular outfit that I actually wore 2 years in a row. I went as a flying monkey from The Wizard of Oz. My sister went as Dorothy, and I got to be the flying monkey. Went 2 years in a row. So from early on, I've been a friend of Dorothy and very proud of it. So I'm happy to talk to you about the Medi-Cal health plan perspective of COVID and cancer and how the two are interfacing. Alameda Alliance for Health is the Alameda County Medi-Cal managed care plan. We have about 260,000 members in Alameda County. We also have a small commercial plan serving IHSS workers in Alameda County, but primarily we're a Medi-Cal plan. And as a pseudo-governmental agency, we're lucky that our mission is really aligned with trying to really help people get better. So improve the quality of life of our members by collaborating with our provider partners in delivering high quality care and addressing the social determinants of health. That's an important part of what we do. Next slide. I thought I would talk to you about some of the key areas and how it was impacted by COVID, particularly related to cancer patients. So from a health plan standpoint, we divide our utilization into inpatient and outpatient. Both took very significant drops, especially in the first months, April and May. We dropped our inpatient volume by 30+% in April and but 20% in May. It started in June and July to come back up more to a normal range, and the inpatient volume has maintained at a more normal range since that time. That has implications, though, for hospitals, because hospitals have Medi-Cal patients and a lot of other patients. The overall hospital volume is not back to normal, which means as a percentage of their business, they have more Medi-Cal and less commercial business. That's not good ultimately for the future of our local hospitals. On the outpatient side, we had a dip in a volume about 25%. What that represents is that's less utilization of services, necessary services for members. I wanted to highlight a couple of key areas to make sure that you knew about them as Medi-Cal benefits. One is transportation. We pay for transportation for members to go to and from the pharmacy, to and from a medical visit. We've seen a dramatic decrease in transportation. Part of that is understandable because such a huge portion of the visits have switched to telephonic or video. Over 3/4 of all the visits that are occurring with Alameda Alliance members are currently happening virtually as opposed to in person. And we've seen a big drop in our transportation. However, we still have transportation available for people to go to and from their chemotherapy, to and from the pharmacy, to and from dialysis or whatever else they need. So those services do remain available. I also wanted to talk about interpreter services. And as I say that, I realize I'm speaking quickly for our interpreters online. Thank you very much. Our interpreter services are a covered benefit for Medi-Cal members, regardless of where they have their Medi-Cal. But we switched from doing 80 to 90% of our interpreter services in person to now doing less than 10% in person. But of course, the vast majority of the rest of them, because we're continuing with the same volume of interpreter services, are now being provided telephonically or by video service. So those services are still available, but there's been a big pivot in the way we provide those services to members. And then preventive care is definitely the area that's taken the biggest hit. In the next couple of slides, I'll show you a little bit of data. We've dropped significantly, and that delayed care is going to influence future generations. Dr. Bondi addressed that in her presentation. The drop in utilization, if we do not look at as a good thing, it has significantly decreased the expenditures by insurance companies. So insurance companies have less costs this year because of the decrease in utilization, but that does not bode well for the future because people are not getting needed services, and it can greatly exacerbate disparities, as we just heard. Next slide. This slide is from the state of California, the Department of Public Health, and it's the California Immunization Registry, and it compares 2019 to 2020. You can see here in the red circle that there's a significant drop in the ratio 2020 to 2019 for, these are non-flu related immunizations. So more than 3/4 drops in April, down by 2/3 in May, down by half in June and July, and still not back to a normal range. So huge decreases in the general Medi-Cal population. This is not just Alameda Alliance, this is the state of California in terms of vaccination. And of course that can apply to people who need them most, like children and people who are immunocompromised, like cancer patients. Next slide. This is another slide from the state that showed doses submitted by pharmacies. And what I've circled in the red circle here is you can see there's actually more of certain vaccines being given, and this is all vaccines, so given by pharmacies this year compared to previous years. And what that represents is that people are going to an alternative site of care. People are not flocking back to their doctor's offices in the way that they were. So people to their primary care office for a flu shot, which represents a large portion of this. Instead, they're going to CVS or Walgreens. Most insurance has made exceptions this year to allow for that, even if they did not before. But that's something very important for your members to consider, your patients to consider. Can they go to alternative venues if they do not want to wait at their doctor's office? And many doctor's offices don't want patients lining up for flu shots when we still have COVID. Next slide, please. Next is under care management. So that was utilization. Now under case management, we heard, and it's not a surprise to any of us who are living through this epidemic, it's a hard time out there. Patients, everybody feels more isolated, anxious, depression, substance abuse is way up. So we're seeing that in our case management department, in referrals to our case management department, in referrals to our mental health services. And I just encourage people to be aware of that, be aware of it in your own life, be aware of it for the patients that you see or you encounter. Give people a little extra leeway nowadays. I certainly do when I'm driving. Crazier people on the freeway than I've seen in a long time. And just realize people are stressed. The world is a little bit stressed. This is just a chapter. That's what I say to my own patients when I still see patients. I'm an internist by training, not an oncologist. I should have said that. I'm an HIV doctor, ran AIDS clinics for a long time, and then I was a hospital chief medical officer. But I'm saying to my own patients, cut yourself some slack, take some patience. This is a chapter in our life. We're going to get through it, but realize there's a lot of suffering that's occurring right now. Another thing in the case management area I wanted to point out was housing specific to COVID. That includes for cancer patients. In our county, the county through state and federal resources has purchased in some cases and rented in other cases multiple hotels. They have hotels for people who are homeless who have COVID. They have hotels for people who are at high risk, including cancer patients who do not have COVID, but are at high risk living in congregate settings like normal shelters. And then they have special SNFs, or skilled nursing facilities, clustered or segregated for people with COVID or at high risk for COVID. And indeed, that's one of the most important areas. A huge, huge portion of the deaths in our county have occurred in skilled nursing facilities and amongst the elderly and people with pre-existing conditions like cancer patients. So the housing and the arrangements there are critical. Next. Under pharmacy, we've had to liberalize the rules a lot to allow for early refills, extra doses of medications, 90-day fills, liberalization of formulary, because people are struggling to get to pharmacies. People have moved out of town to stay with relatives, so they're out of the area and not able to come for local care. And then many, many members in our commercial line, because Medi-Cal has no copays, but in our commercial line are struggling with their copays for their own employment. That means some members are choosing to go without drugs, others are calling, and we certainly are waiving copays for members if they can't pay them. I want to sneak in one reminder. There's a gigantic transition of the Medi-Cal drug pharmacy benefit occurring January 1st of this coming year, January 1st of 2021, where the state of California will take over in a centralized way the retail pharmacy benefit for all Medi-Cal members in the state of California. So look for that. That will also impact, they'll have a different formulary than your local Medi-Cal plan, and that may influence which drugs some of your patients are able to get. Next slide. Of course, one of our big responsibilities is the quality of care provided. So in terms of access, which is a quality measure, again, I said over 3/4 of our visits are telemedicine, mostly telephonic, but there is also difficulties of access. Many providers' offices are not open the same hours they used to be, especially some of our smaller mom and pop providers, PCPs, are open restricted hours, and that's causing access for people, particularly with acute issues. So we're trying to create other venues for them. And then our quality measures, or our HEDIS measures, are suffering, of course, because of the dips in preventive care. So we have many plans, strategies, outreach, support to the community, support to drive-through flu shot clinics in order to try and get people to be able to access their preventive care. And we have seen that this, as people are getting less preventive care, this has exacerbated health disparities because it's not split evenly amongst our demographic population. Next and final slide. Next is the financial impact, and I split that up into both our members or patients and then the providers. Because this is a very, very hard financial time in the healthcare world. As I said, plans are financially doing better. Health insurance generally is doing better in that it has fewer expenditures. In the state of California, the way we work, the state has already cut our rates to compensate for that. And our enrollment has increased. So we have 10,000 more members than we had at the start of the epidemic. We thought this would be because people are losing their jobs and applying for Medi-Cal. We have not actually seen that in Alameda County yet. What we have seen is the governor, as part of his executive order, stopped Medi-Cal disenrollments. So there's normally every month people who come on, people who go off. Nobody's come off since the governor implemented his executive order in the spring. That also has implications. It means a whole bunch of people could drop off of Medi-Cal when the governor's executive order expires. We do not have an expiration date at this particular point. And finally, I'll close with the provider community, and certainly patients are what we're here for. But in order to be here for the patients, we have to have providers to see them. Our hospitals are suffering significantly financially. They've had a big shift in their volume, a decrease in their volume, a decrease particularly in their commercial volume, which sustains hospitals that see a lot of Medi-Cal and Medicare patients. Clinics are suffering significant increased expenditures, and solo providers are suffering. Truly, some of the people who have had the biggest hit to their finances are some of our specialists who no elective cases were done for a long time, and now elective cases are still being done at a slower rate. So as part of a compensation for that, the Alameda Alliance distributed over $6 million to providers in the first few months of the pandemic as a sustainability fund to try to see them through these tough economic times. Thank you for letting me speak to you. I'll turn it back now to our moderator, Lisa.
Wonderful. Thanks for that perspective, Dr. O'Brien. I think it's great to get that information for all of our attendees. Okay, so if you can continue submitting your questions, we'll be sure to get to them. Let's see, let's start with one that was submitted early on. There was a question about disparities in screening and cancer prevention. And I think I might ask Dr. Bondi to take a stab at that. And Dr. O'Brien, you touched on that also. And perhaps if you could both think about kind of what's going on from your perspective and then what we might do about it. Dr. Bondi, you want to take that one?
Yeah, it's a really good question. I'll start, but I'm going to let Dr. O'Brien sort of finish it up because he's more on the ground and seeing patients that are in his network. I definitely think there's fewer people that are getting screened, and so I think it's going to affect the underserved and uninsured, and it will have an impact on disparities. And that was the point that I was trying to make, is that those most affected would be those that have less access to the care and for screening. Dr. O'Brien, what do you think?
It's a very significant issue.
Mm-hmm.
We see disparities in COVID itself. In Alameda County, if you're Latinx, you're much higher risk of acquiring COVID. If you're African American, you're much higher risk of dying from COVID. So there are significant inequities. And then in terms of our cancer screening, we do find disparities amongst our population, and those are often exacerbated when you have access issues. And that's what we're seeing, is access issue with providers having to close or make themselves available physically less often. And several of the screening tests, as were pointed out earlier, do require some sort of physical presence of the doctor.
Great, thanks, Dr. Bondi. Thanks, Dr. O'Brien. Let's see, I think I'll pass this next question to Dr. Kabibi, and Dr. Schapira, you can also answer this one too. So we've seen that our counties in California are reopening, yet we see in the news that the surge is happening, perhaps not in our counties, but nearby certainly, and across the country and world. How can patients decide what's safe for them? It seems like there's a lot of misinformation and perhaps miscommunication. Dr. Kabibi, what do you tell patients?
Yeah, that's a really challenging question to ask. I certainly ask them to look at their local communities and the incidences and rates and what are the statistics locally that are applicable to them. But if we're talking to a community where we're of cancer patients who are under treatment or undergoing therapy, I certainly encourage them to take the most conservative route and just practice all the typical things: social distancing, washing hands, and monitoring there, and also being aware of your surroundings and the people that you interact with and in your household. Unfortunately, it's not like a clear answer, but that's my general guidance to my patients.
We're all learning as we go. That's right. Dr. Schapira, do you want to add? Thank you so much.
Thank you. I totally echo that. My advice as a physician is always to be conservative and try to keep people safe. So I'll err on the side of caution and reinforce the CDC guidelines of wearing a mask, socially distancing, avoiding being indoors with other people if at all possible, and washing hands often, and using common sense. I think that some of the questions that I hear are also from cancer survivors who worry and wonder if they are now considered normal or they still are considered immunosuppressed. And I would say that that's something that needs to be resolved on a case-by-case basis. But certainly most of the patients who are many months or years from cancer therapies, unless they had specific treatments that profoundly affect their immune system, are considered normal hosts for COVID. So most of the women that I see who are on hormonal therapies for breast cancer or so on are not at increased risk for COVID, and I reassure them.
Thanks so much. So another question that was submitted ahead of time was about vaccines. So we understand that once vaccines are available, that cancer patients will be in the top priority given their immunocompromised status. So perhaps, well, any of you can take this. Dr. O'Brien, I know you've been working with the California Department of Public Health on the rollout of vaccines in Alameda County. Can you talk a little bit more, perhaps, how that might be operationalized for cancer patients?
Well, I'm proud to say the state of California has done a lot of thinking about this. They have a preliminary plan. There is going to be a distribution network that's going to have to include a lot of local providers. And there's going to be prioritization guidelines, and they're going to go off of national standards. There's national standards actively being developed, and the state of California will base their prioritization guidelines off of the recommendations. They anticipate when vaccine is first available, there will not be enough vaccine for the whole state, nor will there be a network broad enough to vaccinate the whole state. So there will be a short-term supply and demand issue related to vaccine. That's when the prioritization would come in. They're going to prioritize active healthcare workers, of course, for logical reasons. And in that phase, which they call phase 1, phase 1B is essential workers and high-risk medical conditions, which absolutely could include people with cancer. Exactly how that's going to roll out, more details to follow from the state and from the specific guideline recommendations that come out.
Thanks, Dr. O'Brien. I think we should also assure our attendees that California is going to do additional safety reviews of the vaccine. Is that correct?
Yes, absolutely. You know, the good news is there's going to be multiple vaccines, and there's going to be a lot of vaccine. There's going to be a relatively short period of time in which there's going to be judgments that need to be made. And absolutely, there's lots of scientists, including at the state of California, who will be looking very aggressively at the science behind the vaccine development and the safety. That's a very, very important factor. And, you know, I myself will be looking at that issue for myself, for my patients, for my family.
Thanks so much. And just to put a plug, our town halls in November and in January will focus on vaccine trials and vaccine readiness. So we'll have more to come on that. Dr. Kabibi, did you want to say anything to add to what Dr. O'Brien said about vaccine rollout and what cancer patients should know?
Yeah, you really have to be humble in terms of developing vaccines. I heard a really nice quote that said that nature gives us its secrets slowly and often with a human price. So, I mean, you have to remember that millions of people who get this vaccine are healthy and often may never get COVID. And so we have to really hold that to a high standard of safety. So as Dr. O'Brien has commented, I really want to ensure that the science makes sense for myself and my family and all my loved ones and my patients, and then, see how we, decide on the rollout of who gets those vaccines.
Great, thanks so much. So back to you, Dr. Bondi. We had a question submitted asking, what exactly is herd immunity and what should we know about it in relationship to this pandemic?
So there's a lot of discussion about how people could just live in society and live without protection. And there's the question about herd immunity is that in many ways, it's let people be exposed and get it, because the more people that have the antibodies would allow others to not be contagious, which is kind of crazy because right now the numbers of people that get it, for herd immunity and COVID, we really need to have the vaccine in operation where we have 94% or so of the people that would have antibodies build up, that the others who are around them would be less likely to be infected with COVID. But until that happens, we can't achieve herd immunity. It's just not achievable until we have a vaccine, and that's the concern. And some of the discussions that the president has been saying is that we should allow herd immunity to for people to be infected, but that's really not how herd immunity works. So I'm really concerned about that whole idea, and we want people to protect themselves. And the numbers of cases today are highest that they've been since the pandemic started. And that's really a concern, and a concern for our cancer patients who are immune compromised, who would be exposed to people and maybe unknowingly that they have the infection. They could be symptomless for a short time. So I think that, as all the other speakers said, wear your mask, wash your hands, keep socially distant. And at this point, until we have a vaccine, we can't expect herd immunity to be feasible.
Thanks so much, Dr. Bondi. I am going to switch gears a little bit. So we keep saying staying socially distant. But Dr. Schapira so eloquently brought up some of the emotional and mental health consequences of this epidemic, which for cancer patients and cancer survivors can be particularly troubling. So we had a question submitted asking, what can we do to support cancer patients and cancer survivors, perhaps virtually, and so we can stay socially close but physically distant?
So I'll take that if you want to. I can certainly, and I'll invite anybody who has a perspective. But yes, this is a very important question that you bring up. And we can either deal with it now or wait until we see the rise in mental health syndromes like anxiety and depression in the future, or substance abuse, or many other things that have already been mentioned. And I think that intervening now is important. So for every cancer survivor and every caregiver, I think it's important to sort of try to do a bit of a tally of how stressed people are. So it begins with some self-awareness of how people are tolerating the stress. Some people may be lonely, and perhaps in that case, what they may need is to see a friend, perhaps outside, sitting, 2 meters apart, 6 feet apart, wearing a mask, but being in the same place, just having a conversations. For other, it may be longing to see a grandchild who is 2,000 miles away and they haven't seen in a long time. Maybe then you can use technology if possible, and do this, remotely. It's not going to be the same as a real-time hug, but those are the things that I think people need to understand what's going on in their life. Now, as a physician or as a researcher in the space of psychosocial health, I'll say that, some of our colleagues in industry have been working very hard, and there are now some free apps that people have developed that are really good to deal with COVID-19 stress. And they are offered free, and there have been subsidies to get these technologies developed. So anything that deals with relaxation, stress management, mindfulness practices, physical exercise that can help reduce or mitigate stress, practices like yoga, perhaps all of these things can help people to sort of reset their levels of stress so they feel a little bit better. Social connections and being with somebody else who feels, for a warm interaction, if family or friend, is really important. Some people may feel very lonely because they're not able to go and worship in places where they used to congregate as communities. So that's where we need to be really creative and resourceful and think of ways of helping others and also articulating our own needs and reaching out. There are many organizations in the US, philanthropic organizations. I'll mention a few: the Cancer Support Community, Cancer Care, national organizations. They are doing as much to support people online as they possibly can. And again, there are apps that have been developed to guide people through some very simple cognitive behavioral therapies to help reduce stress levels. So there's a lot out there that we're happy to connect people with. There are many resources. and we should not wait. We should really, I think a very important message that I give my patients is, and I did that this morning in clinic, is don't wait till you're desperate. If you feel stressed, ask for help. We know how to help and how to support people.
Thank you so much, Dr. Schapira. That's great advice. So related to that, during the pandemic, many more people have faced job losses and shortages in being able to buy the food they need to eat, and even trouble with housing. Dr. O'Brien, maybe I'll pass this to you. What can people do? What resources are out there when people don't have resources to meet their needs, like healthcare, food, housing?
Well, that's a really important question. It's a very tough time. And as people know, it's been a very divergent epidemic in how it's impacted people economically. And there are some people who are absolutely devastated, completely unemployed, and it's very, very problematic. In terms of insurance, the first thing I'd remind people is if you've been working and you lose your job, think about COBRA. COBRA can be expensive, but COBRA is a benefit that can apply to people when you lose your job, or you can continue your previous work employment for an extended period of time, but you have to pay for it, and not everybody can afford that. If that's not an option for you, if you can't afford it, then absolutely think about applying for Medi-Cal or Covered California, which are other plans that can help. Many people receiving Covered California health plans receive subsidies for those health plans. There is a unified application. It's the same application for Medi-Cal as it is for Covered California. And if you go on the state website, there's a link where you can apply for Medi-Cal, a link where you can just apply under Covered California, and it will tell you whether you qualify for Medi-Cal or Covered California. That's probably the best way to do it. It's a significant application, as you might suspect. It asks all the questions you'd think about, your demographics, of course, your income, do you have access to any other insurance? It takes an hour or so. You also can go to your local county. Your county runs through the Medi-Cal application process. So when you apply online and you fill the Medi-Cal application online, it will go to your local county to be processed. And they will determine ultimately whether you meet eligibility criteria, excuse me, in your county. And again, on that same website, and I'll send the link here, I'll put it in the Q&A section also. There's a link that has access to all the counties in California and their particular social services agency. Also at the social services agency is where you can apply for things like food assistance and other programs that may be of help. There's many, many other community-based organizations, but that's a great place to start, is with your county social services agency or at the state website for application for Medi-Cal and Covered California.
Great. Thanks so much, Dr. O'Brien. That's really helpful advice. And thanks for pasting that in the chat or the Q&A. So Dr. Bondi, I think it would be great if you could tell our attendees a little bit about the research that we're doing at Stanford, both related to COVID and COVID-related problems.
Sorry, I couldn't get my mute off. Lisa, thank you for asking that question. There's a lot of people in our own Department of Epidemiology that are doing research in terms of testing and testing for seroprevalence. There's the CATCH study, there's the VIRUS study that many of you have heard about. One of our faculty is working with counties to help them better understand how to move a little more quickly with understanding the pandemic and looking at specific areas of where outbreaks could occur and how to deal with those kinds of things. On the cancer area, there's people looking at the genetics of the COVID. There's people doing a lot of studies with trials looking at the effects of remdesivir, of other monoclonal antibody types of treatments. So there's so much work being done at Stanford and around the country. In terms of cancer, I know that Dr. Schapira might want to speak to this, but they're doing things related to national studies, and I'm going to let her talk about some. She mentioned some of those in her talk, and so did Dr. Kabibi, of the work that's being done nationally. The National Cancer Institute is spending an enormous amount of money working on vaccines and other types of continuing a lot of research that's going on. Many people pivoted, who were not necessarily working in COVID, and pivoted to do more research related to COVID and trying to understand more about long-term and short-term effects of the infection.
Great, thanks so much, Dr. Bondi. We also, if anybody's interested in getting involved in research, on our website where you registered for the town hall, you can also sign up for the patient registry to be contacted about opportunities for volunteering. Let's see, Dr. Kabibi, I realized we had a question that was submitted for you, and it was one of the first ones, and I didn't ask it yet. So somebody submitted a question asking if one of their family members shows signs for, if you're a cancer patient and one of your family members shows signs of COVID, what should you do?
Yeah, it's a great question. I mean, first and foremost, that family member needs to be tested to determine if they truly have COVID or not. If they happen to be COVID positive, the guidelines do recommend that the patient should be tested, but not tested right away. We know that if patients are tested too soon, that there can be a significant false negative result from the testing. So we know that most virus shedding, based on publications, happens about 2 days before the onset of symptoms, and then a day after this development of symptoms. And you won't necessarily have a detectable nucleic acid amplification on a PCR test, that's fancy words, to detect the virus until maybe about 3 to 5 days after your exposure. So I think certainly first off, I would talk to your oncologist and let them know about the exposure and the positive exposure, and then plan for testing and certainly more aggressive monitoring of any onset of symptoms. You may need to talk to your oncologist about getting some lab work to determine if you have an adequate amount of immune cells and white blood cells if you're undergoing treatment, and certain guidance thereafter.
Great, thanks so much, Dr. Kabibi. So we are nearing the end. I hope we have gotten to most of your questions. Before I ask the panelists to go around and give us a kind of final word for their hopes, perhaps from now through the holidays, I want to thank each of the attendees for coming. We really think that getting informed, in addition to washing your hands, wearing a mask, and staying physically distant, is a great way for us to prevent transmission and control the COVID pandemic. So tell your friends to participate and come, and thank you again. So we're going to go around with the panelists, and I would love to hear your final thoughts for our cancer community here at Stanford. Perhaps what your hopes are from now through the end of the holidays. I think we don't want to look too far ahead during the pandemic. Can be overwhelming. So we'll start at the top. Dr. Bondi, you can go first, and Dr. Kabibi, you'll be next.
Well, I think we all should enjoy Halloween. No, I'm just kidding. I think it's going to be a really hard time right now. We're seeing this spike, and I think, to be on a positive note, and I think, Lisa, you're saying it, is that we all have to be careful and be considerate of others and try to support each other as much as we can. And I know how hard it is that we all want to see our families, and we need to do what we can to stay healthy and to follow good practices.
Great message. Thank you so much. Dr. Kabibi, how about you?
I would just encourage everyone to take care of each other. I think that, everyone is undergoing their own stress with managing through this pandemic, and we have to almost be more caring, I would say. And I really just impart that as we're going into a season of giving and sharing. And it may not, as Dr. Schapira has expressed, not look the same as it has been in the past. And we need to create a new experience and a fruitful and optimistic experience, hopefully with our friends and families. But yeah, respect and taking care of each other and looking out for one another is what I really want.
Thanks so much, Dr. Kadidi. Dr. Schapira?
So to quote Winston Churchill, we should not waste a good crisis. This is a crisis. And I think that as scientists and as citizens, we should try to learn as much as we can about how to communicate better using telehealth, how we can support each other, how we can learn from all of this, and then be part of the solution to build a stronger system for supporting members of the communities, particularly those who need that extra help.
Wonderful. Thanks so much, Dr. Schapira. Dr. O'Brien, you get the privilege of closing us out with a last comment. No pressure.
Okay, great. Well, thank you. And thank you, everybody, for really insightful and positive conversation. As probably the oldest panelist, I'll say perspective is very important. This is a chapter. This is not our new lives. This is a chapter. So I'm telling everybody, keep in mind, we're going to get through this. It is a time of very significant change and a time of profound impact. And that is a time for reconsideration, which we're seeing in the country as a whole. And most of all, keep in mind, I feel lucky. I'm lucky to have a job. I'm lucky to work from home. I'm lucky to have a house. This is a time where I'm thinking a lot about the people who are not as lucky, who are more challenged physically by this illness, more challenged economically by the crisis that we've all had to endure to keep people safe. And so I'm going to be more grateful this year, encourage people to reach out to others and think about those who are not doing quite as well.
Thanks, Dr. O'Brien. Really important always at the holidays and especially now. So thank you again to everyone for attending. We'll bring this town hall to a close and we'll look forward to seeing you on November 19th when we'll talk about all you wanted to know about vaccine trials. Be sure to leave us messages in the chat. We always take suggestions, criticism, recommendations, whatever you have to say. Wonderful. Thank you, everybody, and have a good evening.